Okay, we're going to go ahead and get started. Thank you so much for joining us today. I'm actually going to step onto the stage, but hopefully you'll be able to hear. Thank you so much to the students today for being present. As you can read, my name is Dr. Charis Chambers. I am a board certified OBGYN and fellowship trained pediatric and adolescent gynecologist. I also graduated from Spelman in 2010. I was a biology major, and I distinctly remember sitting in this auditorium 16 years ago, roughly over there, because I felt like it wasn't too close to the front, not too close to the back, and talking about being a biology major with the chair of the department and wanting so desperately just to become a doctor. I just wanted to know how I could get into medical school. And I remember they asked us, raise your hand if you want to be a physician. And all of our hands shot up in the air. And then they kind of followed with, maybe about 4 of y'all will actually do it. I was like, oh my God. And I came up to the microphone and said, okay, so if that number is 4, how am I in that 4? And of course that was awkward. They were just like, oh, and so that was my mission as a student to figure out how to make it. Because I'm not interested in your statistics. I'm not interested in some discouraging statement. I'm interested in the future that I know I have for myself. And I knew I wanted to be a physician. And so I say all that to say this is a full circle moment for me, because I distinctly remember being in here and wanting to be in this place. And so I think the Charis of 16 years ago will be elated at this moment. But I do want to kind of highlight the topic for discussion today, medical advocacy. And this is a part of the Reclaiming Wellness campaign that the Honey Pot Company has put on that is sponsored by Target. And so we do have some products in the back. We'll talk about that a little bit later. But I do want to just thank you warmly for being here. This means more than you know. And this topic is near and dear to my heart. Let's get started. So, my little clicker has failed me. Let's see. I might need help clicking. So to start, when it comes to understanding how to be a self-advocate in the land of medicine, you really must unlearn this entire equation. This equation that says the good patient that meets the good doctor gets the good outcome. And I think you have to unlearn that because there's so many misconceptions as relates to what the good patient is. What were we taught was a good patient? You can shout it out. Do you have any, what are some of those features or characteristics of a good patient?
They exercise.
Exercising, yes. Skinny, yes, also that. Yep, taking their medication, following directions, not asking too many questions, not being too argumentative, making sure you come to every appointment, follow the first recommendation, all of those things. That was somewhat conditioned in our minds of the good patient, especially in the Black community, when we're entering to these hospitals that weren't built for us, and we just don't want to create another barrier to our care. And so that led to the misconception of the good doctor, with doctors being perceived as almost godlike. But their patriarchal approach to medicine, whatever they recommend, it must be in your best interest. Whatever they say, they must know what they're saying. They must know everything because they are the doctor. They are the authority in that relationship. And so you must submit to their plan. And that's what we had in our minds previously. And then that should guarantee you the good outcome. But we learned over time that that wasn't the case. And that really happened when we started to understand and share a lot of media and information. And over time, it's like, doctors made a mistake. Don't you know they cut off the left leg and they should have done the right? Like, that's a big deal. And they started to actually really examine the quality of medicine and what that looks like, and what the training looks like, and the failures of doctors and healthcare systems. And I learned that by going throughout the training. And so I went into the Facebook archives to find this picture. This is a picture of me, my intern year as a resident, OBGYN resident. And I was located in a place that I thought was fun at the beginning. It's called Triage. It was the emergency room for obstetrics. I basically lived there. It was my hell on earth, okay? But you learn by triaging patients. They come in with their complaints and you take care of them according to what the emergency is. And in obstetrics, a lot of things are emergencies. And it was in this place that I learned that that equation had failed me, that my goal to be that good doctor, to meet that good patient, to hopefully get that good outcome, didn't always work, and there were other factors at play. I distinctly remember possibly my third year meeting a patient in triage. Now, I had kind of graduated from being the intern in triage. So when I went to triage, it was like, because I could, it was kind of cute, like, okay, I'm gonna help you or whatever. And so I went in there because I saw her strip, looking at the contractions from remote. I said, something's wrong with her. She was contracting way too often in a way that was concerning for something called a placental abruption. That's when the placenta is separating from the uterine wall, and that's an emergency. And so I went to go see her, and she was a young, small frame Black girl. And I said, are you okay? She was like, I'm in terrible pain. Her blood pressure was elevated. I looked at my team and I said, we need to get her to an OR, to a room now, not an OR, like a labor and delivery room, and prepare our minds for potentially going to the operating room. Because if the placenta separates, the baby has no nutrients, no blood flow, and it is an emergency. I told everyone, told the nurses, told everyone, and I looked at her, I said, I'm gonna take care of you. And I believed that because I was going to. And so I made sure that she got her lab work done. It was stat. I stalked the lab. I literally kept refreshing the screen. Like, is it back? Is it back? Is it back? As soon as it was back, I called the nurses because the nurses were the ones that needed to call the anesthesiologist to get her an epidural. And so I went to go check and let them know the labs are back. They are fine. She can get an epidural. Do your job, do what you gotta do. And then so I came back to check on her about 45 minutes later, and she had not gotten an epidural. And I looked at her nurse, who I looked in the face when I came up there. I said, where's her epidural? She said, oh, we're going to finish this patient first. And so me being me, I looked at that patient, looked at the room and looked at the chart to see, like, who is this? It was a private pay patient, white woman, third child, not a medical complication in sight. And I said, but I told you to prioritize this patient for a medical reason. I don't even have to be up here anymore. I can sit in my lounge, but I came upstairs to tell you multiple times to expedite this epidural, and you didn't do it. And she said, well, she's not even in pain anymore. She's not hurting anymore. So, well, she's still contracting. Let me go check on her. I went into the room and I sat on the end of her bed and I said, are you hurting? And I could very faintly see tears rolling from her eyes to her ears. And she said, yes, but it hurts too much to talk. I walked out of that room so angry. And I remember saying, she is in pain. You didn't even check on her. Get her the epidural. And so I sat there and watched them with my eyes just looking at them like, we're going to do this? This is what we got to do today? Okay. And they got the epidural. But by the time we got it, the baby started to compromise. The heart tones went down. We had to rush back for an emergency C-section. There was confusion with the medications that she got, getting the paralytic before the anesthetic, all of these things. It was one of the worst blood gases, which is a determination of how the baby's going to do that I ever had in my training. I was furious. And so I immediately started to type. I was like, we documented today. Guess where I learned to document? Here, you document everything, right? And so I documented the heck out of it. So I went there this time. I had timestamps for everything. I went here this time, I did this at this time, and I reported it. Because I said, if I'm going to be here at this institution in my Black skin, being this person who looks at my patients and says I'm going to take care of them, I'll be darned if they mess this up for me and mess it up for my patients. I was so disheartened. And so once we put in that report, we had to do a committee review. Of course, they were mad. They were so mad that I put in a report, and I didn't say overt racism because I was like, they're not even gonna read it if I say racism. So I said, this was caused by implicit bias. And I've been doing a lot of reading on implicit bias. There was all this training at Harvard and all these great institutions about implicit bias. And the thing about implicit bias is that everyone has it. So you can't argue that it isn't there, right? And so I said, this was based on implicit bias. I explicitly stated that this patient needed to be prioritized, and they still gave this to a patient who did not need this from a medical standpoint. We had a meeting weeks later, and the nurses were livid. They were like, how dare you say that I am biased when I have, on my medical training, I'm not biased. I'm like, do you know what the word means? Like, I'm just like, how is this possible that you would say? So the meeting was completely unproductive, and the person who was presiding over the meeting, the physician, the most senior physician, concluded it by saying, I don't believe there's any implicit bias here. And this is obstetrics and gynecology, where the Black maternal mortality rate is 2 to 3 times the white counterparts, and they don't believe that there's implicit bias here. And the conclusion was that I hadn't communicated well enough, that it was a communication error. And that's what it was logged as. And that was when I said, oh, this is how they do it. It doesn't matter that I'm here, that my burden of context of being here says I'm going to take care of this patient. It is a system. And this system will never know this story because they wrote it down as a communication error. Even though that baby went to the NICU and didn't have to, even though that mom experienced pain that she didn't have to, this is written down as communication error. And that's the systemic aspect of things. And I'm not going to tell you all these terrible stories, but I want to really kind of let you know what this means and why my experiences make it so that I feel like I'm able to approach this topic. Thank you. So the definition of systemic racism is that it is racism that's embedded into the policies and practices of a society or institution or organization. And so medical racism is just that, right? It's going to be that within the system of medical care or healthcare. And so this means that it's not just an isolated person or thing or something that one guy just happens to be racist and everyone's like, oh, not the racist guy. Like it is all throughout the medical system in a number of ways. And I want to go through just some of those ways, but it is just the tip of the iceberg. I want to pretend to say that I'm touching on all of them. So when you think about the history of medicine and racism, people who were taken captive from Africa, who actually touched foot on the soil here, one of the first things and first people that they came in contact with were the physicians of the day. Their job was to evaluate them to see if they were sound, to dehumanize them and do invasive exams, and to really place value in some pseudoscience sort of way on who they were as people. And not really people, just as property, so that they could get a higher bid. And that was the first interaction. This is your doctor? That's who they were using in a professional role to advance racism. Women who were enslaved were experimented on by J. Marion Sims, who they tout as the father of gynecology. I was actually taught that, the father of gynecology. And the reason he became the father of gynecology was because he experimented on enslaved women to perfect his technique for fistula repair. It was repeated vaginal surgery without anesthesia on the same 3 enslaved women, Lucy, Anarcha, and Betsy. And the thing that really betrays that this wasn't just some cute little scientific endeavor, he wasn't just a devoted scientist, was that only once he perfected his technique did he start operating on white women. And when he did so with anesthesia. And I would be in the OR where they would say, hand me the Sim speculum. And I'm like, we really doing this? Like this speculum is named after him. We use it for all of our cases. And he's a tribute kind of thing, you know, fun fact of the father of gynecology. And you completely dismiss the racism that laid the foundation for him to make any of these advances. How is this possible? So there are other disparities in medicine I'll touch on briefly. BMI categories, everybody knows that. That's not for us, right? These were based, I mean, just genuinely speaking. These were based on life insurance tables from the 1930s. Guess who that didn't include? Us. There was a bunch of white males primarily. And so we use that to create BMI categories to then say that you're obese or you're, you know, severely obese and all of those things. And then that puts more Black people into those categories than maybe they should be. And you know what that looks like when it comes to BMI stigma and the ways in which people blame BMI on the patient. And so it looks like this patient is failing and not the system. And I don't think that's by chance. Another category is renal function. There were some studies done very, very early where they decided that Black people had a higher creatinine, so we needed to adjust for their renal function. So what that looks like is when my renal function is really bad, it makes it look like it's a little bit better. And so maybe I won't get that referral to that renal specialist. Maybe I won't get on that transplant list, right? Maybe I won't get that medication withheld that will harm my kidneys further. And these are things that are perpetuated. More recently, they've decided to try to remove that race factor, but it was added in to adjust for things. The same thing for lung capacity. It was Thomas Jefferson in the late 1700s that said, you know, there's a difference in the lung apparatus for Black people, which is why they're so well suited to work in the field, right? Medicine, justifying racism, it's everywhere, it's all the time. The mortality rates, we talk about mortality rates and maternal mortality, with Black women being 2 to 3 times higher, more likely to die in pregnancy or with pregnancy-related deaths. Having a 40% higher rate of death with breast cancer, right? And then research dollars. Research dollars, famously for sickle cell, are always so much lower than anything else, even though it's so prominent. And so these are the ways in which medicine and racism are intertwined. So someone might say, well, why can't we just fix this with equality? Why can't we just give everyone the same thing, right? If we give everyone the same thing, then that should be fine. The problem with equality is that it doesn't take into consideration the different needs. And that's why we say equity is superior to that. So equity actually understands their differences in needs and then allocates resources according to those needs to hopefully get an equal outcome. Okay. And so one of the situations in which I realized how the equality piece could never really work for us. It works for the majority. Yeah, if you weren't harmed by it anyway, sure. If you started the race early, yeah, let's all just get 10 minutes. I mean, you know, that makes sense for you. When I was in residency meeting with the chair of the OBGYN department, this was towards the end. I was in my 4th year, and we were talking about departmental diversity, of course. I was the only Black resident, and we had one other Black faculty member who had just been hired the year before. And we got on the topic of racism and bias, appropriately. And he very proudly said, you know, I think of myself, and I'm even raising my children to be colorblind. Don't see race. And I just looked at him. Now, for context, I was in my 4th year of OBGYN residency. And so if you don't know much about medical training, medical school is 4 years, and then you go to residency for like 3 to 5 years. My residency was 4 years, okay? What I mean to say is I was about to graduate, all right? And I don't know if there are any graduating seniors present or anyone who knows what that looks like, but there's a certain shift in spirit that occurs when you're close to graduation, right? And so I knew I had 2 choices. I could either let him comfortably finish his story, or I can make it really uncomfortable. So I chose the latter. I said, you know what? I'm gonna have to be honest. When you say that, when you say that you don't see race, what I hear is that you have to do some crazy mind over matter, mental mastery to forget that I am Black to treat me right. So much so that if you saw it, if you acknowledged it, that my treatment would be subpar, which entirely betrays the bias that your blindness is trying to hide. So you don't need to forget that I'm Black. You need to be learning how to respect me in my Blackness. Another conversation. So I was like, okay, bye. So I realized that there's a lot of people in leadership. Now, he was one of the senior most physicians in this hospital system, talking about some colorblind. And I said, well, that's not appropriate, especially in the context of like Black maternal mortality. If you come into an OBGYN and they just treat you like anybody else, knowing good and darn well that you are 2 to 3 times more likely to die, that is a problem. Just like if you had a child with asthma, you wouldn't send them to a school that doesn't believe in asthma. You're just gonna run the child just like every other child and won't let them have an inhaler. Like nobody else gets an inhaler, you can't have an inhaler. Why not? They're at a much higher risk for complication. You need to treat them accordingly. And to treat them accordingly, you have to see the diagnosis, you have to see the risk factor, you have to see them. You have to see race. So I hope all of that has laid the groundwork for the importance of medical self-advocacy, because you really can't even start that process without understanding the context, the history, and the validity of things. And I really think that step 1 of medical self-advocacy is validation. Validation in the cause, validation in the need to protect something, validation in the purpose of medical self-advocacy. Because if people are gaslighting you and saying, this doesn't exist, no one's mistreated you, no one mistreats people, then you might not believe it. I literally was on a Zoom call just yesterday with my medical school alumni association, where they talked about the first Black medical students who graduated in 1971. And we had the privilege of having one of their very white classmates on the line who said, you know what, I know them. And I tell you, they didn't experience an ounce of racism. They were just like us. I said, sir, I know you not. Fly on here talking about they didn't experience racism in Birmingham, Alabama in 1971. They were probably afraid to walk home. And you're gonna sit here on behalf of them saying, we treat them just like our own. So, sir, you're not gonna lie to me on here. Now, I didn't upset the whole thing, but I was like, this is how it perpetuates, right? So they will lie to you. They will hurt you and tell you that you liked it. You know, the axe has a short memory, the tree has a long, because they're creating the harm. It's so easy for them to forget it. And so you have to know that this is real. You are not crazy. You're not playing the race card. You are protecting yourself. Oftentimes you're protecting your life, your fertility, your child's life, your functionality, your mobility, your sanity. There's so many things that are worthy of protection and they need to be protected. And they are not going to be protected just by getting a Black doctor because the system is at hand, right? And then there's education. You can just walk in there and not have any ounce of education as relates to your body, the disease process, whatever you're dealing with, right? From an education standpoint, I think the most important part of that is to realize that you need to be the expert in your body, in your history, in your health. You need to talk to your family members. You need to know what runs in your family. You need to know what you're allergic to. You need to know, what medications you take. You need to read that consent that they gave you and told you to sign. You need to read the insert in your medication that talks about the side effects and the things you shouldn't take with it, right? That's how you advocate for yourself, by being educated. But you should be somewhat selective about the sources that you use, okay? The TikToks of the world are cute, right? They're nice. I'm on Instagram, you're a doctor, you probably know that. But it doesn't mean that should be your source of medical education, right? There's better resources, cdc.gov, youngwomenshealth.org. There's a number of resources that you can utilize that are appropriate, that are official, that are sound, that are medically accurate. And don't you know, if you bring up that good resource, okay, what does CDC say? That really allows them to say, okay, this person's not playing. And partnership is huge. So you need to find a team that works well with you, right? People that you feel like you can trust, that listen to you, that don't dismiss your complaints, that understand that as a Black woman or as a person of color or whatever, you are going to be at higher risk for particular reasons, and they can see that in the fullness of who you are. So sometimes that partnership looks like partnering with a doula or a midwife or a nurse practitioner or a doctor or a therapist, a physical therapist, an occupational therapist, whoever you need on your team to be successful. Work on those partnerships. That's how you advocate for yourself, build that team. And a lot of people are like, well, how do I find that team? That's a great question. There's a wonderful platform called Health in Her Hue, literally spelled health in her, and then Hue is H-U-E. It's created by a friend of mine who decided that she wanted to make a platform where Black women could reach culturally sensitive and appropriate doctors. So it's a directory for doctors in a ton of specialties who are committed to taking great care of Black women. It also provides community and other opportunities to talk with other people who might be dealing with something you're dealing with. They have communities where they talk about fibroids and mental health and all these other things. And so I think that's a great resource, because your partnership should also be community. You shouldn't feel like you're the only person who deals with this diagnosis or has this family history. When you talk with other people, you can say, oh, I didn't ask my doctor that. I'll ask them that next time. I didn't know they offered that. I will, ask them about that next time. And then engagement. That's step 4. You can't just go in and show up and just say, all right, I'm here. You need to know what you want out of that visit. Know what you want out of that visit. Know what your I'm not leaving here withouts are. I have those every time I go to the doctor. I've been called a difficult patient, and I wear that badge proudly. Like, I don't care. I ask questions like, well, last time you said, because I've written it down. I always bring something to write with. I ask to get my lab printed out. I ask why things are happening. I say, now, is there another opportunity to revisit this? How long am I going to be on this? Is this the only medication? Are there any newer medications that have come out? Is there another approach? Okay, if you want me to get a transplant, when would that be? Why would that be necessary? What does it look like if I don't? What is my prognosis if I choose something else? What do other people offer that you have not offered me today? Is there something that is another treatment option that you are not well versed in, so you don't offer it here, but someone else does? Okay, those are the questions that I ask, and I don't care if they look uncomfortable. It is my life. It is my health. But I do ask them in an appropriate way, because you don't want to be too aggressive or too off-putting. You want to actually give people somewhat of an ability to partner with you. But that's what that engagement looks like. And so when I think about medical self-advocacy, it looks different for everyone. But if we start with validation, and then we have that education, we can partner, we can engage. It's a continual thing. You wash, rinse, repeat as much as necessary. You never tap out of engagement. And so I want to talk about some guiding principles, because as you navigate spaces in life, and as you navigate, interacting with different healthcare providers, and you go through a variety of diagnoses or illnesses, sometimes you are even taking care of a parent. a loved one, you really can't always have a step-by-step guide of what your next thing is, right? Sometimes you have to be flexible. Sometimes you have to kind of be creative. And so I like to have some guiding principles when it comes to decision-making on a repetitive basis in like a dynamic scenario. I think one of the most important guiding principles that I would want you guys to know, and what I've learned in my medical training as I watch people interact with their doctors, kind of like a fly on the wall, because I wasn't like the attending, but I could really observe these things. Is your body your choice? Truly. And some people think that that is just a very powerful statement, something it's like hand off my womb, things like that, which is good, but it means a lot more. It is your body and you get one. So you need to treat it accordingly. And you need to own your choice. Every day I present choices to my patients and they say, well, what do you want, doc? I trust you. I'm like, I appreciate that you trust me, but you have to decide. I'm not taking your pill for you every day. I'm not the one that has to have this procedure done. I've made my choices. I've gotten through college. I chose my birth control. I don't need to make this choice for you. You know what your goals are. What are your goals? Do you want to think about your fertility every day? Is this pain debilitating? Are you over this? And that's just a choice only you can make. I will educate you through it, but I'm not going to force you either way because it's your choice and you need to own that choice. And so when you realize that, and you realize that you have the power to make the choice, then you start to be more engaged. You start to weigh those risks and benefits a lot more. So your body, your choice, that's a very real statement that comes, when it comes to physical exams or whatever anyone might do or want to do for you. And understand that declining care is not always advocacy, okay? Just declining everything or disagreeing with everything, that's not critical thinking. That's just being adversarial. That is not advocacy. And I find that very often today. People just say, no. Whatever they offer, no. Whatever they recommend, no. Then what? What is your point? What is your next step? What is your basis? And you ask them to follow it up and they don't have one. So it's fine to decline things, but know why you're declining it. Don't decline it out of fear. Get the facts and make a choice. But declining and just arguing, that's not advocacy. That's recklessness. And it doesn't really allow for there to be an appropriate relationship when it comes to the healthcare system. I find, and this was a lot in my training, people say, she just doesn't listen to anything. That's the worst difficult patient. I walk in there and be like, Miss So-and-so, what you do? What did you do? What did they do to make you angry? What is wrong? And oftentimes, if I sat down and just let them talk, or if I just said, what are you most worried about? What is your biggest fear? What are you not telling me? They would say, well, I'm just afraid that I will never be able to have kids again. They did not consider, they didn't counsel you well enough in this. And it's not that they didn't say that this is reversible, but the historical context of things and what your family has told you, you have to address that again and again and again. And so I say all that to say, they will draw conclusions about you sometimes, and it makes it easier. There's already bias there. They're looking for you to prove it, that you don't want to be well, that you don't want to be healthy. And sometimes that blanket declining of care can really perpetuate that. Another guiding principle, which I will just fight for the rest of my life, is that second opinions save lives. And research supports this, especially for breast cancer, especially for Black women. There was a small study of women with breast cancer who were sent for second opinions. It was all like reputable, oncologists, and every single patient had a change to their plan. Every single patient had a change to their treatment plan. And one patient, her treatment plan changed so drastically that like nothing was the same. She entered into remission and she was able to give birth to a daughter because she got a second opinion. Okay? A lot of people think that second opinions are disrespectful. That maybe if you ask your doctor who you've had a relationship with, can I see someone else? That they might be offended because you don't trust their judgment. But again, going back to unlearning that equation, don't believe they know everything. They can't know everything. In this land of information and abundance of knowledge, you can't know everything, and they can't always offer everything. Get a second opinion. The truth is that a good doctor is not offended by a second opinion because they want you to be sure. They want to know what their colleague says. They're like, yeah, I said the same thing. Yeah, I'm doing the standard of care. They are too. And they should be able to back that up. Okay, so second opinions save lives. Next, doctors are human. Doctors are human beings who are doing their best sometimes to serve you and to be as up to date as possible. But things are changing every single day. And we saw that throughout the pandemic, right? As people were like, wear a mask, don't wear a mask, wash your hands. It doesn't, it doesn't stay in the room. All these things that changed. Asymptomatic people can't be carriers. And then it changed. You know why? Science changes. Science continues to change. It is impossible to know everything that changed every single day. And so what I mean to say is enter into these situations with healthcare providers and with the medical system with some amount of grace. You are interacting with human beings who lead lives just like you. They have bad days. They forget things. They have trouble sometimes. Okay, so doctors are human, and that also means they can't know everything. They're not God, and you don't have to do everything that they say. And then finally, this is my favorite one. There is no award for the best behaved patient. Who cares if they're upset with you? Because you asked a question? Who cares if they label me as a difficult patient because I wanted to know the cause of my kidney disease? Who cares? There is no award for them. The award is life, choices, freedom, fertility, seeing your kid be okay, seeing your loved one come out of the ICU. That's the award. You don't need to be trying to seek to get this approval from the system that wasn't necessarily built for you. Okay. All right. That was abrupt. I do want to switch to questions, but I wanted to give you guys some of my contact information so that you could know how to reach out to me via Instagram or via email, my website. I also have a YouTube with some, few videos there because this conversation is one that could last forever. I also wanted to make sure that we had adequate time for questions so that we could talk about situations maybe that you've been in before with yourself, with family members, where medical advocacy was a difficulty, or maybe we could talk and create community here and partner together to come up with a solution. But thank you for your time. Thank you for your attention. Thank you for the attention of everyone who's online as well. I can't really see very carefully there. If you guys have questions, I imagine they can put them in the chat as well. If you're virtually attending, yeah. Any questions at all? We do have a microphone too. I ask that you would go to the microphone to ask your question, just so that the people who are on Zoom could hear you. Oh, yeah. Sorry. Any questions at all? And I'm sorry, we do only have one microphone because I wanted the other one.
First of all, I love you. I follow you. So, just wanted to say that I'm also in a PreMed Track right now, and I was wondering if you could set gap years and if you did, how to decide to do it.
Okay. For the people who are on Zoom, the question was from a PreMed Track kind of point of view, if I took gap years and how I decided to do it. I actually did not. And I'm not saying that I highly recommend that exactly. I had to kind of do some personal evaluation, and I knew that I was fairly certain with what I wanted to do. I didn't feel like taking a gap year would reinvigorate that for me or allow me to kind of fine tune my studying. I felt like I just wanted to kind of roll through. But I know people who have taken gap years and they've done exceptional things. Sometimes people take gap years to just do research. Sometimes they do something that's completely not related to medicine, but something they can at least talk about in their interviews and such, because you don't want to just have a year of time that you can't even touch on. I think the idea of a gap year is super important and super helpful, but it is very person specific. If you feel in your heart that you want to take a gap year, do it. There is no hesitation. There's no issue from the admission side of things when it comes to people taking a gap year. It's not like they're like, oh, they didn't go immediately through, they must not want to do medicine. I would argue that people that take time off in between going from undergrad to medical school to residency or whatever are more in tune with what they want because they've lived a little, they've maybe traveled some. They've done another, type of work or entered into another field or something of that sort. And so their commitment is actually stronger sometimes. Let's answer your question. No, I didn't. Thanks so much. Any other questions? Hi.
I was just wondering when you're seeing a new doctor or therapist or any other medical professional as a Black woman, what kind of questions should you ask?
Oh, that's good. So the question was, if you're seeing a new doctor or therapist as a Black woman, what kind of questions should you be asking? That's like your first new patient visit. And I really believe in kind of almost dating the doctor, trying them out, seeing if they're a good fit. But I don't think you should be like quizzing them, like, what are the top 3 causes of hypertension? Like, that's kind of ridiculous. They will hate you. But I think you should ask things specifically in the context of OBGYN is what I typically kind of lend, my examples to. I would ask questions like, well, what do you think about the Black maternal mortality rate? Right? They should have a thought. You can't just be an OBGYN and not have a thought about the Black maternal mortality rate. What are you guys doing to improve that? What is the rate at your hospital? What's the C-section rate? Does that differ by race? If you are looking for a provider to deliver you, do you deliver all of your patients? Ask about things that matter to you. And sometimes you need to make a list of things that are important to you. I need a doctor that I can reach. I need a doctor that I can get to pretty quickly, that I can schedule an appointment for. Things like that. If you are very, holistic in your approach, you can say, well, what do you think about holistic medicine? What do you think about, therapy and hypnosis and acupuncture and things of that nature? If they're like, oh, that's trash, if they have some very strong kind of response to that, then maybe that isn't the best doctor for you because you do want a holistic approach. Now, I think that we should be thoughtful in the ways in which we approach doctors as, we want them to maybe do everything, right? The reality is we do not go to a pilot and say, hey, I don't want to take a plane, but I'd like to know how to get from A and B by car. Like, you're just like, what? Like, you do transportation, don't you? So it's a little much in the sense that doctors are medically trained. So we typically go to them for the medical side of things. To go to a doctor and say, I only want herbal remedies and I only want you to do meditation. You're probably not going to meet that doctor right where they are. They may advertise themselves as such, but you should be looking for a doctor that fits you and fits your goals and your priorities. So asking those questions just to see what their response is, read their cues, read their body language, see how they respond to you. And they should be able to verbalize a stance. Okay. Other things you can test out, things like, well, when do you think it's appropriate for someone to be placed on medication? What are the things that you look for before you recommend surgery to see how conservative they are in their approach or how aggressive they are in their approach? Or, when's the last time you changed an approach to something? Or what are the latest guidelines on something, so that they know. You can ask them questions like, do they go to conferences? Do they have colleagues that they discuss cases with? You can ask about their specializations. Are they specialized in robotic surgery? Do they have some specific non-invasive approach? I think it's very, very specific to the person and what your needs are and the specialty, but asking questions that kind of lean their personality and their overall approach to things is probably the best way. You can't anticipate every outcome or every scenario that you'll go through with your doctor. And so that's unrealistic. But basically you want to see what are their goals? What's the future with them look like? What does it look like being a patient with them? I'd also argue that the best way to find a doctor is ask your friends. Ask your friends who they see, right? Because you can ask your doctor and I can recommend someone, but I've never been to them as a patient a lot of the times. I just think they're cool in the doctor's lounge or I follow them on Instagram. It's not the same thing as being their patient, which is a very unique position. I hope that answered your question. Yeah. Or do you guys like the you want to pass it? Questions on you guys? Just for context, that's my sister. I do not have, she's a very unpaid employee. Of the Bureau.
Thank you. Hello, Dr. Chambers. Thank you so much for speaking with us today. It was very motivational. My name is Michaela Sweet, and I am also a bio major in a PreMed Track.
Wonderful.
And something that stood out to me throughout this presentation was how you talked about the implicit bias. And my mom, she works in the medical field, and my junior year of high school, I worked at a neurosurgery clinic as a medical records clerk. And then just sitting there and like taking courses at Spelman, like I know you take a DW. And so just like, you know, correlating that with like the age, race, sex, and class, it just shows like you being a Black, how intersectionality plays a really big role in how you're treated within like the medical world. I'm sorry, I'm nervous.
You're okay.
But yeah, and it's like saying like me being a young Black woman, already my age, my gender, and me being young to make people think, oh, she doesn't know that much. She probably doesn't know that much about what's going on in her body. So it's kind of like easier to like manipulate her and to get into certain procedures, and a lot of procedures that like, especially like with older people, I noticed this like at the neurosurgery clinic I worked at, it was a lot of more older people who were there, and like you can just see when they were doing they were watching like the surgery consent videos, a lot of them did not understand what was just really going on. Like yes, they'll click through the videos, but a lot of times sometimes they wouldn't just like read through it, because like they'll ask questions in it, and sometimes they wouldn't read it, so I read it out to them. And then they'll like, wait, what does that mean? Or da 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 da. And in my head, it's like, if I wasn't there, would they genuinely know what they were signing up for? Because a lot of times they don't know like the difference between having local or general anesthesia, or how invasive the procedure is going to be. So I just think like it is a lack of communication at one point, but like a certain time it is implicit bias going on.
Oh yeah, that's such a great point. I'm so glad that you commented on that, because I remember, gosh, when I was in medical school and just watching the ways in which people describe patients and the ways in which they counsel them. And I would just be looking at the patient's visual cues like, she got none of that. I remember I was counseling a patient on birth control, which is my favorite topic. I was so proud of me because it was a young girl. And so patients would, in the ward, when we were delivering people, when they wanted to go home, we would try to at least counsel them on their birth control options and give them something if they wanted something before they left, because they were there. And a lot of people don't show necessarily for their postpartum visit. There's like a 50% show rate. And so when people didn't know about contraception, but I knew they didn't want to have a baby soon, then I'd be like, okay, let's talk about it. I'll do my little spiel. You can tell me what you like, right? So I was really proud of myself because she was like, I want an IUD. Yes. So I was walking out the door and she was like, one other question. I was like, okay. She's like, what's a uterus? I said, oh my God. I said, let me sit back down. We have failed you. This is a girl who just delivered. She was a very young teen mom, but she just delivered. And no one had explained these things to her. She had just kind of gone along with so much, and it was so wild to me because the majority of her care had been centered around the uterus. But I think, interchangeable words, womb, things like that. So I use all the words. I take nothing for granted anymore with my patients because so much of our health literacy is taken for granted. And so it just perpetuates it. And so you have people that come in. I talk to patients about their periods, just baseline stuff. And I'm like, you don't get this lesson if it's in social intelligence. I'm sorry. And I'm not sure who doesn't know it. And their mothers or grandmothers will be like, no one has ever told me that, like ever. And I'm like, okay, I learned something. I'm 65. I'm like, okay, because we fail so much, especially as medical providers. And so I know you said you're pre-med, which is amazing, and that makes me very happy. Obviously, if you're other majors, I love you too. But I want us to know this so that when we are in these situations, we do make a difference. I didn't want to convey that we're not making a difference, but one doctor, we can't overcome a system of bias. The system has to be undone, right? We make a huge difference for our patients. And so please never forget that. Never forget how important it was to look at them in their eyes and say, does this make sense to you? Do you understand it? Sometimes I would even say, okay, tell it back to me. And they're like, I can't. I'm like, okay, let's try it again. And it takes time. And the medical system doesn't like to reimburse for time. Not in that way. And so it is a little bit harder. It's challenging, but it's worth it. It's a great question.
So we have a question from the chat.
Okay.
And it says from Janine, Dr. Chambers, I use a planner to put my questions in, symptoms, and more to take to the doctor. Do you have any suggestions of how we should be prepared when we go to our doctors for caregivers and patients.
Oh, I love that. Love that. So I always say bring something to write with, right? Because you're just, it's hard in those scenarios. You're gonna be nervous. I mean, I'm nervous talking to you. Like, so it's just like, you're gonna be nervous. It's hard to remember things when you're nervous. It's hard to remember things if they give you bad news. If you're going in to check on your labs or something like that, it's hard to remember what they say next. And so having something to write with is hugely important. And preparing outside of the room. When you're at home and you're comfortable on your couch and you know you're going in, that's when you want to write your questions, okay? Because your mind is clear. Don't be doing it in the car on the way there when you're in the waiting room and you're freaking out. It's better to ask or to write down those questions and know what that matters to you before you go in. And I also make a list of like, do not leave here without. And I'm like, Charis, do not leave here without this. Like, do not leave here without a plan for this thing. Do not leave here without them addressing that symptom of swelling that you were experiencing. Do not leave here without understanding what this looks like in your future fertility care. Those are the questions you need to get answered. If they can't answer them for you, you need a referral, you need a resource or something. And so I even put things down to reinforce for myself what I'm not going to leave here without. And I would also say, if you have people in your family who are in healthcare or someone who understands the sciences or understands a disease process or something, bring them with you if you can. Obviously with COVID, things change, but I actually had a line sister who would send to multiple line sisters who were in medicine. We got anesthesia, we had a ton of things, recordings of conversations between herself and the ICU staff when her parent was sick. And we would all listen to them and all say, that don't make sense. Ask her this, follow this, what will be the parameters for this, and give her a list of questions. She'll put them together and then call them back. And we created a team. We were basically like a little round table of specialists so that she understood what to ask about her father at that time. Okay, so what I mean to say is there's ways to be prepared. There's ways to utilize your resources. Go in there with an action plan of questions, an action plan of who I'm going to run this by to check it out, and then something that says, I don't want to leave here without this. I think those are some of the ways. Now, if you come see me, as it relates to periods, have some information about your period. People are like, my period's irregular. I'm like, okay, like how so? Do you write it down? Like, no. I'm like, okay. When was your last one? I don't know. I'm like, okay. When did you start having periods? I'm like, oh, I'm like, I don't, help you. So no, I'm not saying you have to like, dear diary, I got my first period today, right? Sorry, breast development today. That's very weird. Don't do that, but you have to be able to have some engagement and attunement to your body so that you know when these changes happen. Because we do different things according to the timeline. Was this an acute onset? Does it respond to this? If you have nothing to add to this picture, my differential is that much wider, and I'm that further away from getting to the answer for your care. So that's how you advocate for yourself. That was a great question. Thank you, Janine.
Hi, Dr. Chambers.
Hi.
My name is Brian Coleman. I'm first year in my major is health science. I'm kind of like on a pre-nursing PreMed Track.
Yeah.
I want to be a nurse only because I do plan on taking a gap year before med school, and I'd rather spend my time being a nurse because, like you were saying like earlier, like a lot of the implicit bias it lies right there in that nursing line.
Sure does.
Most of the work, but they spend more time with patients, and they do most of like getting what the patient needs or what the doctor needs for the patient. And I just feel like being a nurse first, maybe I could somehow like help like implicit bias. And then with me being a doctor, I would know like automatically, like I may not need a nurse to know what the patient needs because I've already seen it like firsthand. And I just also feel like there's just a better way to take care of my gap year. And I'm also my specialty would be also treatment gynecologist.
Oh, I love that. That's amazing. So what she was saying, if you couldn't hear on the Zoom, is that she is in a health sciences major, first year, and wanting to do nursing as a gap year so that she could be practicing as a nurse during her gap year and kind of clarify her approach to medicine that way. And that's amazing. I love that. Please do that. That would make you an exceptional physician. And I'm sure people would love to have you as a nurse. But the nurse view is hugely important. I cannot even begin to tell you the things I learned from nurses. They taught me how to suture. They taught me everything. They really did because the experience level was so significant, especially in labor and delivery. And so I love that for you. I think that we can really change lives from any role in the healthcare system, nursing included.
My name is Sydney. I'm a first year.
Hi, Sydney.
So I feel like in the Black community, especially when young girls want to go see an OBGYN, it's often seen like in a negative way, and a lot of Black families will kind of relate it to, oh, if she wants to be an OBGYN at a young age,
recommend for young Black girls to kind of have those conversations with their families, to see an OBGYN just for the sole purpose to have, I guess, more knowledge on like their reproductive health and not in such a negative, like dehumanizing sense?
Such a great question. So for the people who are on Zoom, Cindy asked, in the Black community, when young girls want to go see an OBGYN, a lot of the times it's attributed to being sexually active or there's some sort of negative connotation. How can these young girls kind of enter into these conversations with their parents so that they can go to see these doctors just to get established with care? It's almost as if I planted you there, Sydney, to ask that question, because it is my favorite. It truly is my favorite. It is what I'm actively trying to change as it relates to the culture of medicine, the culture in the Black community when it comes to reproductive health in the earlier years. And so I mentioned previously that I am a board certified OBGYN, but I actually did a fellowship called Pediatric and Adolescent Gynecology. And so that just means after my 4 years of residency, I did 2 more years of fellowship in Houston at Baylor College of Medicine, which was a great institution, learning how to take care of folks who are 21 and under. And so this is my population. This is what I do. And so I fell in love with this as a medical student. I was seeing a mother and daughter duo, and the girl, she really just wanted to figure out why her periods were irregular, so she knew what to pack to go to her away basketball games. That mom was like, I need to know she's not pregnant on a monthly basis. I was like, oh my God, what a difference in goals, you know? And so it was amazing to see the generational differences as it relates to the Black community and Black mothers and just the unlearning that is necessary when it comes to our own bodies, right? A lot of the times when moms do bring in their daughters, they bring them in 3 ways. One, they follow me on social media and the mom's like, ah, and the daughter's like, I hate this. 2, the mom is like, she is sexually active. I caught her doing something, please fix it. I'm like, oh, okay. Or the mom is like, I have suffered for years with debilitating periods, terrible pain, and I'm terrified that my daughter's about to go through the same thing. Those are the main reasons I see folks. And they're all good reasons. But the issue that I have is that I just want my daughter to be established with care, whatever, to see a Black doctor kind of one, and my daughter has debilitating periods and I don't want her to go through the same thing, maybe negatively kind of pictured as, oh, she must be doing something she's not supposed to be doing, right? And so some of those patients in those categories just never come because they don't want to be thought of as whatever. They don't want to have any assumptions drawn about them. For that reason, we suffer so much longer than we need to. Or we bring our daughters in too late. I've had people bring in their daughter. I'm like, well, unfortunately, she's actually pregnant. We have to do that conversation because the mom, for whatever reason, didn't want to approach that. So a lot of my social media is bringing awareness to that because I do think it's hard for daughters to lead that conversation. I think it's hard to feel the authority in your home, right? This isn't some like even like Dr. Patient, you both experts type things like that's your mama. Like she's not gonna, you know, I'm not gonna have you fight your mother. Like I'm not gonna give you that advice. But the idea is to feel empowered that this is a real thing. So as an OBGYN who sees teenagers, I see them, it's a real thing, it's needed, it's necessary. Okay. The recommendation for the first age for your OBGYN appointment is 13-15. And that's by the American College of Obstetricians and Gynecologists. And the reason they recommend between 13 and 15 is because the average age of starting your period is like 12 and a half. And so you can come in, tell them about your period, see if it's normal, see if there's any issues. Because a lot of our issues that arise as it relates to our reproductive health, endometriosis, terrible debilitating pain, heavy menstrual bleeding, even some bleeding disorders, they're already there when you first start your period. A lot of women who are diagnosed with endometriosis in their mid-20s and 30s, they're like, my periods have been hurting for decades. And nobody listened. Because we only start to listen to women a lot of times when they're like, I want to have a family. And what we know is if we start earlier, if we were to start medication to prevent the chronic and progressive nature of endometriosis, maybe we could preserve that fertility. If we brought in our daughters who are sexually active and gave them that guidance and the testing, maybe we could treat any infection and prevent it from ascending into the reproductive tract and causing fertility issues in the future. Or if we prevent them from having PID or some other terrible infection that could cause an abscess and actually be life-threatening. Maybe we can prevent them from having an unplanned pregnancy, right? The reality is a lot of the moms come in, when we talk about birth control, they're concerned about 2 things. They don't want to give their daughter the green light to go out and have sex. And I always counter, didn't you catch her having sex before you? Okay, she doesn't need that. She doesn't need it. She doesn't need you to give her birth control for her to do that. Birth control does not change the inhibitory kind of signals in your brain. It's not alcohol. It's not weed. It doesn't change your decision-making capacity. It doesn't change the child you raised. So do you want to protect her or not? And moms sometimes say, you know, I just told her to stop having sex. Like, okay, how'd that work? How did that work? Right? Because look at you, you're still here with me. Okay? Did that work for you? It doesn't work. Scolding your child is not a form of contraception. I say that often. And so when people hesitate to bring their child into the OBGYN, it is largely because they need to deal with the skeletons and the issues that they carry personally, the judgment that they may have experienced when they were younger, the fears, sometimes the traumatic experiences they had with their first daughter. So another thing I do with my first patient visits, I say, listen, this visit is for you. And I point at the daughter, like, this visit is for you or the teen. I'm here for you. Your mother or parent is here for you, but only you can make this visit successful. So I'm going to ask you what we're going to talk about today, and I'd love for you to engage with me. I have 2 rules. You don't have to talk about anything you don't want to talk about. So if I bring up something you don't want to talk about, you pivot, we go somewhere else. And you don't have to have an exam. And some of the moms look at me like, what? You know, how dare you, you know? And I'm like, no, because I care more about her trusting me and not being traumatized by this experience and just gathering some information that I may be able to get some other way. And then once they realize that, oh, it's a much better experience. And I also find that mothers are the ones who are most moved by the approach of the visit. I've had moms cry in my office because they cannot believe that their daughter has someone to talk to who doesn't scare them, who may listen to them, who believes that they're in pain. They're so emotionally kind of overwhelmed by that fact, which is sad. That shouldn't be a rarity. But anyway, I went a number of places with that, but you know, it's hard to advocate for it. I want moms really are the ones who need to lead that. That's why you're the parent, and your job is to raise a functional adult. And you need to deal with whatever issues you have as relates to birth control doctors, and then find the doctor that's best for your kid. Yeah. Oh, sorry. I think the mic is over there. Hi, Julie.
I'm a graduating senior political science major, and my question is a little bit more comical, I guess. You talked about TikTok and Twitter, and I know as young women, we have like events or trips or whatever that you want your period to come or you want it to wait. So like, what is your perspective on like the concoctions that they tell us to like mix up and drink in your period to come or home?
So for people who are on Zoom that may not have heard, the question was related to some of the TikTok concoctions that are supposed to delay or perfectly time your period. So I feel like I am the appropriate person to address this, as I've trained excessively in this land. So when it comes to periods and what determines the length and timing of your periods, that's largely hormones, right? And so what we use to change periods are hormones. We're not that creative, right? That's what we're gonna do. That's what your body uses. And so the nature of your body is that it basically waits for there to be the presence of a hormone and the withdrawal of a hormone to trigger a bleed, okay? And so all of the concoctions, for example, like the lemon something or lime, like looks like a little shot, but sans vodka, like or whatever, like there's no alcohol. That's not gonna do anything, like at all. And the girl, I think in the video, y'all, I was so mad about this. She like took this like drink and it was like 3 hours later, no period. It's like, that is not science. What? That's not scientific. Like, oh my God. So what I mean to say is there are ways to time your period. I do it all the time. And I think it's really important. Like, why have an inconvenience of a period on a day where you're wearing white uniform? And I, do this for my cheerleader patients that are athletics, that are swimmers. So basically what you need to do is have some sort of hormone present that's consistent. You just don't withdraw that hormone. And so if you take your birth control pills consistently, you skip the placebo row, you shouldn't have a period. And there's a possibility of breakthrough bleeding, but that's how you do it. That's how you time it. And there's no medical adverse outcome as it relates to continuing to take those pills, because the period that even comes with your kind of birth control pill pack, so that placebo row at the end, that's not medically necessary. Basically, what happened when contraceptives were first brought to the forefront was that women really wanted to see their period. A lot of times they were on contraceptives without their partner knowing. So if their partner didn't see them have a period, they think they were pregnant. So they made it so that there was a placebo bleed that doesn't do anything medically, not necessary, just so that they could have that sign to feel better. It is a pretend period. It is not a real period. So you can skip it. So basically the way to safely skip your period is by partnering with your doctor so that you can get some guidance on the right birth control to allow that to happen. Other ways of skipping periods are typically unhealthy, Okay, as it is the fifth vital sign, and you should be having your period if you're not in medicine to avoid it. That's a great question. It's one of my favorites because I think when we approach medicine in that way, it doesn't always have to be just because of health. It can be because of social things. I am healthier and happier when I do not have my period at the beach, right? So that all falls into wellness and being an advocate for your care. So that was a great question, Jill. Thank you.
Hi, we actually have a question from the chat.
Okay.
It says, Dr. Chambers, I have Crohn's and I need a gynecologist that knows about women with Crohn's and the disorders that we get with Crohn's. I went to my gynecologist at my primary hospital with symptoms and she kept telling me it was bacteria, but I researched it already and told her it was not. So I had to find another gynecologist after research that did know. After my exam, she told me what it was and said it was something we get from Crohn's.
So the reality, I think this goes back to one of my guiding principles. Doctors are human, right? The nature of knowing a ton about gynecology and also then knowing how that affects Crohn's is very specific. Crohn's disease is very specific. So people, they specialize in Crohn's disease or autoimmune disease or gastrointestinal diseases, but there isn't a lot of crossover. And the idea sometimes that you would have a doctor who basically specializes in you and your unique combination of medical illnesses is very, very hard. It's hard to find that. It would be hard to search for a gynecologist specialized in Crohn's. Now, sometimes you can find at certain organizations, if there's a Crohn's survivor group or something, Crohn's, living with Crohn's kind of groups, and even just support groups, you can find people say, well, my gynecologist knows about me and we've gone through this. And sometimes people become specialists because of the patient population that they serve. Right. And so a lot of patients with whatever kind of diagnosis or condition, we go to this doctor for our dental care. We go to this doctor for this. I think that's where you really start. But the idea that a specialist would also kind of have some special kind of training in your diagnosis is not something that is reflective of the ways in which we are trained, which is unfortunate. It really, really is. But there just isn't a lot of crossover there. There may be a gynecologist who has an interest in it, but there's not a specific training track in which someone studies Crohn's disease and is then a gynecologist. And so that's very challenging. I want to actually commend this person for doing that research and getting another doctor, right? So maybe someone who's a better fit, someone who may not know and not say, hey, I'm the gynecologist who knows a lot about Crohn's, but they're willing to try and they're willing to look into it and not, going to dismiss what you found to be your truth. So I think that's the best part about that story because it really gave us another way to be a good advocate for ourselves.
Hello, I have actually 2 questions for you. So I know doctors, all of them go through like basic training. So my question is, does better insurance mean better healthcare? And then how can you ensure quality healthcare regardless of your insurance? And my second question is, so sometimes when doctors will explain treatment to you, you don't know if you're missing out on information that they're giving. So how do you know what questions to ask and when to get a second opinion if you don't know that you're not getting the whole story?
Okay, those are great questions. So I'll start with the second one. So how do you know to even ask for a second opinion or to ask the right question if you don't know that they're withholding something from that story? And that's the part of the education component. If you rely on your doctor to be your only source of information, then they control the information that you get. And the reality is most of our doctor's appointment visits are like 15 minutes. I can barely tell you about myself in 15 minutes, and I know me very well, right? It's time constraints. And so what we are taught, especially in our training, when it comes to counseling patients, you tell them the most common things and you tell them the worst things because everything else fits in between. And so if you counsel a patient and you're like, hey, anytime you go to the surgery, there's a risk of paralysis and death, and they sign it, well, they probably would have accepted the kind of local paresthesias, just as it relates to kind of logic. You cannot, and we cannot cover everything. It's impossible. And we can't just print out a book of things like, it's your burden to read that, but that's not fair either. Because most people don't read the things we print out in the office if it's too long, which is why I stick to like 2 pages. So what I mean to say is, always ask questions. I mean, if there's anything you don't understand, ask questions. If you feel like this did not sound like the full picture, there's something in your spirit that just doesn't sit right, I would say, is there something that you're leaving out? If I went to another specialist, would they present this exact same list, or would they possibly add some other things? That's something. And I would go for a second opinion if you have any discomfort whatsoever. If you find yourself at a crossroads for decision-making when it comes to treatment plans and you can't decide, that means you need something else. If your doctor's just like, call me back when you decide, then that means that they're probably at a point where they're not going to counsel you further, potentially. And someone else, another view, another eye on your chart and your record may be better, okay? Now that first question, does better insurance mean better healthcare? Such a great question. One could argue that it shouldn't, right? And there's always going to be situations in which doctors take a variety of payers. And I certainly don't look at insurance before I go into a patient's room. It's one of the, I couldn't tell you what my patient's insurance is, but it does play a key role in a lot of things we do. When I order imaging, my nurse is like, what insurance I got? Because I need to know if they need to go to this place or this place or this place, or if their copay is going to be too much, or if I need to get a prior authorization. So what it does is it changes the way in which we can actually give you care. So I can come up with every plan in the world. Your insurance may be like, I don't cover that, I don't cover that, we're not doing that, I won't pay for that. And so if that's the case, what I'm not able to do is skip to the hospital and be like, we're just gonna do this surgery, I promise you I'm good for it. You know, they require me to present a prior authorization from the insurance company to even get to the OR. And so if you have better insurance in a sense, and they approve it sooner, maybe you'll get it covered sooner and you'll get in sooner. And if it's a time sensitive issue, that's a big deal. Obviously there's the emergency kind of thing. So I think that kind of answers the other part of the question. You know, if like, you know, if there's any way to kind of overcome that. So EMTALA, that's an actual policy that was passed where if people present to the emergency room, you have to care for them. You have to take care of them. And so you care for people in an emergency setting. So if it's an emergency thing, if it's time sensitive, if it's urgent, if it's life threatening, then you can do it without ever evaluating their insurance, and then you deal with it later. But oftentimes, if that patient's uninsured, they now have a huge bill, right? Because you did this life-saving procedure and it was tens of thousands of dollars. And now what? And so that impacts when people present to care, right? So people who are uninsured, you know, they will fix everything at home. They will go to TikTok and be like, what is the remedy for this? Okay. So that impacts the ways in which people present to care, their willingness to even come into the doctor, the frequency with which they come in. And so insurance coverage is important. It plays a big role. It should not be the determination or the bottom line when it comes to your care, but it plays a bigger role than we sometimes give it credit for. I hope that answers. Yeah. Welcome.
Hi, I had a question about like, because I know that you're not supposed to put fragrances in sushi or like
I love it. We're safe, safe place.
fragrance kind of like pads or anything, but then company kind of does that, but in the name of wellness. So I'm kind of confused. And I didn't want to ask this question because you're kind of sponsored.
No, I love this question. This is a real question. So the question was, for folks who are on Zoom, if doctors just say kind of in a blanket way that we're not supposed to use fragrance kind of below in the genital area, then, you know, what do we say about fragrances and companies that actually do have some sort of fragrance, a nice little lavender touch or something? I love lavender. What do we, you know, what's to say about that? So I think we have to be, there's medicine, right, and health benefits, and then there's just like wellness and what I like. Okay, I'm gonna get my nails done. All right, I'm gonna do S&S or dip or whatever. That is not gonna help me in my health. You know, I get that. And there's gonna be some dermatologist somewhere that's like, it's probably not the best, put your finger in UV light, but it stays. Okay, it stays for 2 weeks, and I like that. Or I'm going to the beach, you know. So the reality is, as medical professionals with licenses and credentials, we have to be very thoughtful about what we say. And we have to be able to say there is no, you know, benefit to using a fragrance in that area. There's some fragrances that might irritate you. And so in a general sense, the best thing may be to avoid them entirely. The reality is you might like it. You might like lavender. You might like the way it feels. It might be fine for your body. Your body might do fine with it. What I think is way more important than you just following these blanket guidelines in medicine that don't leave room for culture and variety and personality and all of those things is to figure out what works best for your body, right? The issue I have is when people create these generalizing statements that are so strong, they don't leave room for your personal choice. It is your body, your choice. So you get to decide if you use this or use a product that has a fragrance or has dyes or whatever, and it doesn't sit well with your body, don't use it. And if someone else's body loves it, don't judge them for using it. That's not feminism. That's not sisterhood. What is that? Right? There's room for you to decide. I will give guidance medically. It just says, I can't say this is better. Like if you don't use lavender, your period's going terrible. Like that doesn't make sense, right? I can't say it's going to make your periods better. If you feel like it helped you anecdotally, that's what you use, right? But there's no study that says that having a fragrance in your pad is better for you. And I am medically trained, so I give medical guidance. So that's going to be my stance. I think we need to leave room for that personal choice. I'm so happy with these questions. You guys are asking the best
Hi,
questions.
Dr. Chambers.
Hi.
I'm a senior English major doctorate filmmaking minor, and I've been working on documenting medical neglect, specifically with my mother's. My mother had a procedure a couple years ago, and I noticed that respectability politics played a large role in the way she was treated.
Mhm.
And then I had a very recent issue with my health, specifically with my chest, and I felt like I saw neglect. So I was just wondering if, at what point is it, this is not a good doctor for me? And then is it, this is not a good doctor for people? And I feel like I should take whatever next steps are necessary to address this.
Ooh, that's good. That was good. Ooh, too good. I think when you start to ask the question, when will I know if this is not a good doctor for me? You're already there. I don't want you to wait until you have a negative outcome. I don't want you to wait until there's something that cannot be reversed, until you are actually harmed. There's these things when we're talking about quality in medicine, they're near misses. Like, man, that was pretty messed up. It could have been bad, but nobody died. And then they're just like, some bad. Okay. You always want to catch the near misses to prevent the really, really bad outcome. If there's something in your spirit that says, maybe this isn't the right doctor for me, listen to that, lean into that. Why do you feel that way? Did they dismiss you? Did you feel like you had to say, oh, I'm actually a student at Spelman, for them to say, oh, she's worth saving. She might do something decent, right? I think that's where it really matters. Now, when you're like, okay, when does it switch to this is not a good doctor for people? That's a great question. I have met them. I know them. They practice still. And the reality of the situation is, it is a hard thing to prove that a doctor is not a good doctor for people. You really need a bunch of negative outcomes for it to be proven. And a lot of patients are not willing to necessarily say, oh, they didn't listen to me either. And, you know, because of the way that personal health information is protected, you can't really just say, let me reach out to all the patients who have the same thing as me. Let me see all the patients who needed a breast biopsy and see how they felt, right? Research sometimes does that, but there's always a ton of biases in the way researchers approach. And so I honestly don't know the best way to answer that question. I feel confident about the first one. If you're asking if this doctor may not be the best one for you, if you may need someone else, you probably do. Okay. Kind of.
My mom has been diagnosed with metastatic breast cancer for a few years.
I'm so sorry.
And my question is just, how should I, as her daughter, like a secondary caregiver, and how as my family to really advocate for her and make sure that she's not declining and she's getting.
It's okay. And she's getting like the best care. Yeah. Wow. So I cry when I see people cry. It's one of those things. It's really not great medicine, by the way. But my mom passed away from cancer as well. So I actually took time off of residency to be in that hospital because I was so afraid. Not that she would be necessarily mistreated. This is the hospital where my dad and brother work. They're coming in with scrubs. They know who we are. She's still a Black woman. And I still came down. I missed every day that was allowed to be missing in my residency, to be there, to just ask the questions. And I remember feeling so helpless when I wasn't there. And she called me about just the way she was treated. She was down for like MRI and they left her in the hallway for like an hour and a half. She didn't know what was happening. She was hungry. She felt uncomfortable. She was in pain. No one came to her. And we were so frustrated because even in the context of us being physicians in this hospital, she wasn't being treated right. Just the way people should be treated. I say all that to say, you should worry in the sense of having an adequate concern for that advocacy for her. Being there with her is a good thing. Being a second eye so that you can speak up when she's tired. When people are unwell, when they're dealing and fighting, their body is fighting cancer, their energy is being spent. And so even someone like my mother, who's very assertive, didn't have the energy. She just didn't have the energy to say, why am I still down here? Can I go to my room? I told you I was hurting. You know who did? Me. I had mad energy. Who? I told you to get her some Zofran. If she throws it one more time, I said don't bring her tray without the Zofran. I was walking around like a fool. I really was. And it's okay. I think the ways in which we show up for our family in these moments are very different based on our comfort level, what we understand about healthcare. But I think being present is huge. Now, the last point you brought up was making sure she's not declining care. That's a tough one. Because there is a right as a patient to decline care, depending on if that care is worth it for you, if that improves quality of life, if it's just something that they're just doing to you and you're tired of being poked and prodded, she may want to decline it. And sometimes it's just having that conversation like, well, Mark, what are you thinking? Well, where's your mind right now? Do you want to do this? I had to ask my mom, like, do you want the chemo? Do you want to do this? Do you want to fight? She would say, yeah. You know, her face kind of said, maybe not, but she was tired. People get tired. And it is going to be hard. It's very hard watching your loved ones be sick, especially if their personality changes. They're very fierce and they're kind of more laid back because of that illness. But showing up for them is doing whatever you can in your capacity to support them. And not passing judgment. You have to sometimes remove yourself from that picture, right? She's the one going through it. She's the one experiencing it. There's a book called Plan B by Sheryl Sandberg. And it talks about her kind of trying to be a high-performing woman in the wake of her husband's untimely death. And what she speaks about is the importance of understanding there's a ring of circles. So there's a smaller ring and then a larger one and then one that's larger. The person in the center is the one that's most affected. In this situation, it's your mom. She's the center, right? So what that means is the people outside of that circle be you, people that are closest to her. And then outside of that, maybe friends, outside of that, acquaintances. You love in and you get your support out, right? In this situation, you should not necessarily be looking to your mother to support you to this. You've got to get good support outside of her so that you can show up to support her. Does that make sense? So that would be my recommendation. Showing up, doing those things that we talked about, engaging, making sure she's got the right doctors. We found the best doctor we could find. I mean, we were all on the Googles. Everybody like, no, they had one bad review. No, we can't see them. You know, this one, I know what he's talking about. He's too general. This one, you know, specializes in melanoma. We took her to that one. So, you know, making sure you're partnering with the right people, making sure you're educated, making sure you know her history. By the time I got through the process, I knew my mom's history front and back. I was like, she had a C-section and this year, she took this medication, she did that. She never had this, she has all of this. So knowing that for them, being able to aid them through their advocacy, whatever they're not able to really stand up for and remember and recall, doing that, writing for them, asking those questions, reminding them of those questions, being their second ear. That's how you support. Sorry about it.
Hi, Dr. Chambers. We have a couple more questions from the chat.
Okay.
It says, can you tell me the sites that you mentioned in the education part?
Yes. So I was just kind of throwing those out there. So cdc.gov, you know, the CDC, they definitely cover a number of topics. So things from like HPV vaccination and just things that are highly controversial if you want to know what the research says. And so the most updated research and recommendations can be found there. You can actually go to ACOG, I believe it's ACOG.org, which is the American College of Obstetricians and Gynecologists, and go to the patient section to the frequently asked questions to get a lot of good information about common diagnoses, endometriosis, fibroids, things like that. The other website, youngwomenshealth.org, is one of my favorite websites when it comes to younger women and reproductive questions and concerns like birth control. So youngwomenshealth.org is a really, really good one, possibly one of my favorites as well.
And the next one asks, can you speak on epilepsy and abnormal periods in teens? Doctors ruled out epilepsy quickly, but I've been reading it and it seems the two are related.
So epilepsy, that's a great question. I don't know if many other gynecologists know this, but because my training actually did a lot of epilepsy medicine. So epilepsy can be kind of tied to or triggered by or worsened by the rise and fall of your hormones. And so estrogen actually lowers the threshold of your seizures. So it lowers your seizure threshold, making it more likely for you to have seizures. So people can find worsening of their epilepsy around puberty. So around the time they start to go through puberty and the ovaries start to make their endogenous estrogen. So that is a real thing. Certainly we use medication to kind of stabilize those hormones so that we're not triggering those seizures as much. When people have uncontrolled seizures around the time of puberty, we can put them on birth control. That's progesterone dominant. The progesterone raises that seizure threshold. Epilepsy does not, however, cause irregular periods. There is no reason that epilepsy would cause irregular periods per se. Now, there can be a correlation in epilepsy because there's a number of reasons someone might have a seizure, and that if you have some sort of brain injury, so it's actually like a central nervous problem, injury to the brain, a mass, a lesion that's triggering seizures. It can also be something that also affects the way your brain signals to trigger your periods. People don't always realize that your period signaling starts at your brain. And so because of the vastness of epilepsy, it's hard to say entirely what that looks like, but there isn't a very good understanding of epilepsy causing irregular periods. There would be another factor that causes epilepsy and irregular periods to present at the same time. Any other questions? Y'all, thank you so much. Thank you for your attention. Appreciate you just taking time of your day. I know you didn't have to be here. I don't know that you really probably took notes, but this is a really special moment for me. And I'd love to keep the conversation going. You can reach me on socials and things. Thank you. Yeah. Okay.